Chairman, the live stream is now working. Thank you.
Great, thank you very much, meeting producer. Good morning and welcome everybody to today's Health and Wellbeing Board. Certainly a beautiful day here in Cornwall. If we can start with apologies for absence, please, Leanne.
Good morning. So we've received apologies from Jim Pearce, and Miles Topham from the police is substituting for him. Sarah Newham from the Department of Work and Pensions and Hannah Mitchell were substituting for him. And then we've had apologies from Helen Boardman from the VCF and Jodie Wilson from Health Watch Cornwall.
Okay, thank you very much. Are there any other apologies for absence? No, okay, that's fine. We'll move on to the declarations of interest. If anybody has any declarations of interest, or if anybody wishes to speak, if they could possibly put a X in the chat box, and I will pick it up from there and bring you in. And that's how we'll work the meeting today. So if anybody wishes to say anything, please put a cross in the box and I'll bring you in. I know everybody's got their cameras off at the moment. I think that's fine, certainly helps keep the bandwidth for us. So if you are speaking, please feel free to put your camera on. If there are no declarations of interest, we'll move on to minutes of the meeting held on the 30th of July this year. I'll just have a look at those minutes. Is there anybody who's got anything they wish to raise about the minutes from the last meeting? Are there any comments on the meeting? Please put an X in the box. Also, Leanne has said, could people please introduce themselves with a name and organisation when they speak first? That would be helpful, just so that people watching this is being recorded, so anything you say will be taken down and potentially listened to again and watched again. So that would be good if people could introduce themselves. I know I didn't introduce myself properly at the beginning. I'm the chair of the Health and Wellbeing Board, Adam Painter, deputy leader of Cornwall Council. Thank you very much. Right, we haven't had any comments on the minutes, so I'm presuming everybody's happy with the minutes. I'm happy to propose the minutes are correct. Do I have a seconder? Wondering if my vice chairman's happy to second. Chris Blong's happy to second. Thank you very much, Chris. I presume everybody will be in favour, and those that weren't present at the last meeting will be abstaining. So unless there's anybody who wants to vote against, we will pass those minutes. Cornelius, did you want to say anything?
No, I was just about to second, that was all, but you just took the lead there, so right. And nominated a seconder, so that's all right, don't worry.
I have been seconded. I'm getting nobody frantically waving or putting crosses in the box, so everybody's happy with the minutes, so happy to sign those off as a true and correct record. Thank you very much, members. Questions from the public, item 4. We don't have any questions from the public at this meeting, so we'll look to see whether we get some questions at our next meeting. Then we will move forward to item 5, which is the Better Care Fund and the Improved Better Care Fund update.
Adam, do we not introduce ourselves now?
We don't tend to go around the room, Mike. We will get people can introduce themselves as they speak. So when they come in, or if you wish to ask a question, then we'll introduce people then. So I think that'll be the easiest way. I think most people know each other. I know most people have been on this call before and been part of the meeting last time. So if people introduce themselves, name and organisation, I think that is will be okay. Are you happy with that, Leanne?
Yes, that's fine. It might be beneficial for the members of the public to know who's on the call if we did want to do the introduction. But if people will have to introduce themselves when they speak if we don't.
Yes, I don't mind either way. Is that perhaps quicker if people do just quickly introduce themselves now when we go down through?
I'd prefer that.
That's fine, we can do that, and then everyone will know who's in the virtual meeting room. So I've got a list of participants here. So if I could just call out your name, and if you could just say who you are and your organisation, that would be fantastic. It's in alphabetical order, so we'll start with Amanda Stratford, please.
Stratford, Chief Exec, Healthwatch Cornwall.
Thank you, Amanda. Chris Blong.
Chris Blong, lay member, Vice Chair, NHS Kerno CCG.
Thank you, Chris. Ian Chorlton.
Good morning, Ian Chorlton, GP and Chair of NHS Kerno and Vice Chair of Health and Wellbeing Board.
Thank you. Cornelius Olivier.
Sorry, I wasn't expecting you to get to me quite so quickly. Yeah, Cornelius Olivier, Cornwall Councillor for Penzance Central.
Thank you. Dulcie McBride.
Dulcie McBride, Consultant in Public Health, Cornwall Council.
Thank you. Debbie Bolton, meeting producer, are you happy to introduce yourself as well?
Thank you, Chairman. Yes, Debbie Bolton, Democratic Services, producing today's meeting.
Thank you. Helen Charlesworth-May.
Good morning, Helen Charlesworth-May, Accountable Officer for Kerno CCG and Strategic Director for Adults in the Council.
Thank you, Helen. Jonathan Price.
Good morning, Jonathan Price, Joint Director of Adults and Health for Kerno CCG and the Council.
Thank you. Leanne Martin.
Hi, Leanne Martin, Democratic and Governance Officer for Health and Wellbeing Board.
Thank you. Meredith Teasdale.
Hello, Meredith Teasdale, Strategic Director for Children's Schools and Families, Cornwall Council.
Thank you. Mike Thomas.
Thank you, Adam. Mike Thomas, Cornwall Councillor for Helston North.
Thank you. Hannah Mitchell.
Morning, Hannah Mitchell, Customer Service Leader, Job Centre Plus, DWP.
Thank you, Hannah. Ian Orpin.
Hi there, Ian Orpin. I'm working for the LGA. I'm a former GP and CCG Chair, and I'm currently a non-exec at the RUH, the Run-Out Hospitals Trust in Bath.
Thank you very much, Ian. Rachel Wigglesworth.
Hello, Board. Rachel Wigglesworth. I'm Interim Director of Public Health for Cornwall and the Isles of Scilly.
Thank you. Rob Rothschild.
Good morning, all. Councillor Rob Rothschild, Portfolio Holder, Adult Social Care for Cornwall Council.
Thank you. Sally Hawkin.
Morning, Sally Hawkin, Lead Member for Children, Public Health and Wellbeing.
Thank you. Thank you. And welcome also to Steve. Morning, Steve Bedzer.
Good morning, I'm Steve Bedser. I'm an associate with the Local Government Association here alongside Ian Orpin as an observer on today's meeting.
Thank you very much, Steve. Good to see you. And also Miles Topham.
Good morning, Miles Topham, Chief Inspector, Devon Cornwall Police, working in partnerships.
Thank you very much, Miles. Good to have you with us today. Right. Going back to the agenda. Thank you, members, for everyone introducing themselves. We'll move on to item 5, which is the Better Care Fund and the Improved Better Care Fund update 2020 to 2021. This is quarters 1 and quarters 2. Jonathan Price will introduce the item and just bring up any highlights. We will obviously presume everybody's read the update report. It obviously is a slightly different update report because obviously being in a pandemic such as we are, that has obviously changed the reporting and has obviously impacted on the Better Care Fund and how that is. But if we could ask Jonathan to just briefly go through the highlights of the report, that would be great. Thank you very much, Jonathan.
Thank you, Chair. So as the chair detailed, this is a report for Q1 and Q2. Obviously, COVID has impacted the reporting cycle for the Better Care Fund this year. So this paper really brings an update on the first 2 quarters and provides a baseline for measurement for the rest of the financial year. So towards the end of Q2, work restarted on the fund, and detailed reporting on the substantive items will feature in the Q3 report, and that follows a line-by-line review of the current schemes and expenditure. One key point, due to a personal issue, this report didn't go through the CCG governance process, but was signed off through delegated authority. The report will go back through the CCG governance in the next week or so. In terms of the report, a couple of key points that I would make. DTOC reporting for this year was removed as part of the COVID response. This year's planning guidance has not yet been released, so the 19-20 arrangements roll forward. And we've continued to manage it on that basis. Work has started to now redesign the Better Care Fund in preparation of that guidance, but only once we've received that guidance will we be able to cross-reference and complete the final fund. This year's Better Care Fund reporting does start to bring in the work that we're doing to integrate the wider health and social care system. So this year's report, this quarter's report, features work around those transformation programs in the wider system through Embrace, and also makes reference to the work underway in the council and the linkages between the two. So I think that gives an overview. I'm happy to answer any questions from the board.
Thank you very much, Jonathan. I know, certainly, as you say, the pandemic has certainly impacted and has changed the way that an awful lot of things are being done. Are there any questions? Any X's in the box, please, for any questions on this item? Everybody's content with its content. Hopefully it's fairly self-explanatory. Chris, would you like to come in? Chris Blong.
Yeah, thank you. Thanks, Jonathan, for the report. One other thing I did notice, and I think you allude to it, is the data we've got is very much RCHT Trelisk specific. And I just wonder for future meetings and updates whether we can just try and reach into the east of the county and try and get some more data from Plymouth, North Devon, maybe RD&E, so that we've actually got a more rounded picture, because I think 20, 25, maybe 30% of the population face east, and it would be helpful to get a comparison. Now, obviously, we commission services from Derriford, as you know, but they're sort of directly funded by the Devon CCG. So it would be helpful, I think, just to get a complete picture going forward as to how perhaps there are differences in approach between the different acute hospitals. Thank you.
Hi, Chris. Yes, yeah, I mean, we can certainly broaden the data that we're including in this and bring some direct comparisons between the two hospital performances. So yes, we'll include that in Q3.
Okay, thank you very much. And I guess Q3 won't be too much further ahead as far as the reporting periods, and that will be, I would guess, at our next meeting. Any further questions? If there are no further questions, then could I possibly ask for a proposer and a seconder, please? If you'd like to put an X in the box to propose. Chris, you're happy to propose? So Chris Long propose and Rob Rothschild to second. I'll presume everybody's happy with the recommendations and happy with the report. If there's anybody who wishes to abstain or vote against, please indicate in the chat box. I'll just give a moment for that, but we had, just for members of the public as well, I will just quickly read out the recommendations. So the recommendations are that the Better Care Fund and Improved Better Care Fund update report is accepted, and that the Better Care Fund and Improved Better Care Fund Q4 national submission is noted and accepted. So it's been proposed and seconded, and there's been nobody voting against or abstaining, so I will take that as a unanimous vote. Thank you very much, members. Moving on to our next item, which is the Cornwall and Isles of Scilly Integrated Care System application. Now, this one, I believe, let me just bring my papers up. I believe Helen Charlesworth-May will take us through this one and explain the background to it and where the paper is. It's really very much for noting, as the application has been submitted. I think it's very important that this board has oversight of it and understands the implications behind moving towards an integrated care system. Can I hand over to Helen, please?
Thank you, Adam. So as you said, this is a report that just sets down the application that the local health system has made to become an integrated care system. An integrated care system is the bringing together of the primary health organisations within a given area, in this case Cornwall, to act together on behalf of, in the form of not as a single organisation, because the organisations will stay as independent entities, but to act in concert with one agreed set of objectives across all partners on behalf of the residents of that area, as I said, in this case, Cornwall and the Isles of Scilly. The application has gone in and has been well received. I think the thing I would most want to draw your attention to in terms of the application is that it really identifies how health and care in Cornwall and the Isles of Scilly wishes to address health inequalities as a mechanism for improving the health and well-being of the population in total, rather than it simply being about how do we treat ill health. And given the conversation that we'll be coming on to with the next report, and given the initial considerations by the Health and Wellbeing Board following the pandemic of the primary areas of focus as we move into the implementation of our health and wellbeing strategy, given that that primary focus is inequality, it feels as though it's really important that this board and the members of this board note the application to become an ICS, note the focus on health inequalities, and note that in the future we will want to give real consideration to how we as a health and wellbeing board play a role in supporting the integrated care system with its ambition around addressing health inequalities. There will be a number of us on this board and in this meeting who have seen this application before. There are councillors who will have received the all-member briefing just last week. Others who will have been integral to the to putting the application together and presenting it to our regional colleagues, and ultimately being part of the proposing an integrated care system to NHS England nationally. So this is an opportunity for us all to see the application, for all of us to consider the content of that application, and to ask any questions that we might have today, but really thinking about the fact that this is an opportunity for us to think in the broadest context about how do we as a group of organisations with very strong interest in addressing health inequalities, how do we do that collaboratively, so that we lever the greatest benefit and really amplify our commitment to addressing health inequalities in Cornwall and the Isles of Scilly. I wasn't going to say any more, Adam, so I'm happy to leave it there if that's okay.
That's fine. Thank you very much, Helen. Rachel, would you like to come in?
Thank you. I just wanted to sort of welcome the work as a system, as Helen has said, to focus on the health inequalities aspect, because clearly sort of inequality drives a lot of demand for the health and care sector. So some of the avoidable illnesses, some of the disparity in access and living conditions for our population. So absolutely central to an integrated way of working that will help our care and health system be more sustainable. I think so welcome that, and of course we'll be discussing that a bit further. I think the other thing to note that this is all a journey from the sort of, for those who've kept in touch with the policy, the 5-year forward view, and the sustainability and transformation type approaches. This is a more mature version of that, and it also sort of recognised the partnership that is communities and working with people as opposed to just a redesign of health and care services. So I think this is a move in that direction, which I really welcome as Director of Public Health, because working with our communities and addressing the voices of people within those and the needs is the important bit, not just services themselves. So really welcome this as a whole system plan, focus on health inequalities, the prevention sort of aspect, which is built very strongly into the 5-year forward view approach, needs to be kept to focus on. And I will be looking to those boards that have been established to deliver the programme of work to ensure that we really see that prevention embedded through those programmes. There's not a separate piece of work, it's part of the whole delivery of that programme. So thank you very much.
Thank you, Rachel. Meredith Teasdale next, please.
Thank you. I'll be saying similar to Rachel, but with a children and young people focus. So it's really welcome that we are focusing on reducing inequalities and that quality and quantity of life, and setting that early with our children and young people. The approach around the integrated care system has already seen really good, strong working taking place during COVID-19 across the system to ensure that we are safeguarding and protecting our children and young people. So it stands us in really good stead. So absolutely, this is a programme and a project that needs to be commended and put forward.
Thank you. Chris Blong.
Thank you, Adam. I think obviously we've seen this work previously as NHS Kerno, and supported its application throughout the process. So we're firmly on board with this, and I think the Health and Wellbeing Board will be as well, because it seems we are on the same journey together. I think for me, though, the second part is about how we set standards and how we set the direction. And I know in a later PowerPoint chart further on in the briefing, it shows the ICS, Senate and the Health and Wellbeing Board in the same sort of decision-making box. I may be slightly contentious here, but I actually think the Health and Wellbeing Board, a mandated body in the structure, I think needs to set the lead, as we have been doing, working very closely with the Senate. But we, I think, as a board, should be setting the direction of travel, the expectations, what's required, and then the ICS then delivers that on behalf of the people of Cornwall and the Isles of Scilly. So I think that's what I would call, from my previous background, the command relationship needs to be teased out a bit more about how that direction of travel is identified and then implemented. And I think that maybe that's a bit of work we need to do subsequently. The Senate is obviously in place, up and running, and hopefully we will get ICS status approved earlier than most in the coming months. Thank you.
Thank you, Chris. Cornelius, Olivier.
Yeah, thank you, Adam. I just wanted to revisit a point I raised at the members' briefing last week that Helen referred to, which is I have no problem with the objectives, and believing in the sort of the common purpose of the different organisations involved, but I'm still unclear about how we reconcile integration with the autonomy of the various organisations involved. And I'm speaking, I don't want to revisit past decisions too much, but just as examples, if a particular component of the care system takes a decision that the others aren't very happy with, some form, privatising hotel services at RCHT, or the debate that took place about sexual health services recently, about who was going to deliver that. How are those disputes resolved? Is there an assumption that if most of the partners in the integrated care system are unhappy with a particular decision being proposed, that the organisations that he's out of line will not pursue it? I hope that made sense.
Yeah, certainly. Helen, do you want to come back on some of those points, please?
Yeah, no, that's absolutely fine. So the experience of those areas that have been working much more closely in the way as set out in this application is that they tend to make fewer of those decisions. And the reason they make fewer of those decisions is because they share the ambitions and the motivators before they get to the decision point. So let's address the sexual health one explicitly. If we'd had the opportunity to collectively understand what was driving each element of the system, each organisation, in reaching that decision, it might have been that we could have landed on a different outcome. But the legislation that currently underpins organisations does often drive organisations to make different decisions to those that we might want them to take. Now, at the moment, there is no legislation to make this happen. It is about good relationships, good partnership working and goodwill. But as I said, the evidence from those places that are already working in this way is that the nature of those relationships that are being built leads to fewer contentious decisions. Clearly, there may always be decisions that individuals or individual organisations disagree on. The critical issue then becomes, how do you implement those decisions doing the least harm to the relationships and the least harm to partner organisations? But I am optimistic that looking back over the last 2 years and looking forward to what's to come, I am optimistic that we can start to address some of those challenges that we've seen in the past through this process.
Does that answer your questions, Cornelius?
It does, but I think there's an assumption that, because we're all striving for the same objective and there's a degree of goodwill to each other, this situation won't arise. But I'm simply thinking, I'm simply asking what mechanisms, if any, are there in place when disputes cannot be resolved. For instance, suppose I'm not trying to sort of predict doom and gloom here, but suppose, for instance, our council that we are representatives on decided to uncouple our employees from the foundation living wage guarantee, for instance. And the NHS partners felt that was a bad idea. They wouldn't be able to stop us doing that, would they? So I'm not predicting we're going to, but you take my point.
Do you mind if I come back, Councillor Painter? So as we go into specific arrangements, those specific arrangements are underpinned by a legal agreement. So if you think about my role and the creation of my role as a joint role, it's absolutely within the spirit of this agreement. However, it is underpinned by a formal agreement as set out in legislation about how local authorities and health organisations must work together. So there is and that would happen in every instance. So if you think about the fact that we have Living Wage Foundation, that is a contractual arrangement which the CCG and the council have entered into together. Clearly, they could choose to come out of that contractual arrangement, but there is at present a legal agreement that underpins that. Similarly, with our mental health social workers who work within CFT, that is underpinned by a legal agreement. So this is an overarching arrangement that sets out all those things I talked about: goodwill, good partnership, the right motivations, shared objectives. But every time we take a step into an explicit shared arrangement, that will be underpinned by an explicit legal agreement.
Okay, thank you, Helen. I think Ian was coming in next and may cover off some of those points as well.
Thank you for that.
Thank you, Chair. So I think absolutely this application is, say, a point in time. We've been working on this for, say, some considerable number of years, and I think the application reflects really that how far we've come in Cornwall and the Isles of Scilly, certainly built around sort of relationships and how we work together in the best interest of the population. This is not about creating a layer of authority and the decision making in a new organisation. Far from it. And really picking up on Cornelius's points there, I think we will have failed if we end up looking at the ICS or the Senate to then be giving out decisions based on what partner organisations do. This is around consensus and achieving the best outcomes for the health and well-being of the population. And really, as such as that, and the reason it's come to Health and Wellbeing Board today is because the Health and Wellbeing Board plays a key role there in being able to articulate, understand what the Health and Wellbeing Board strategy is and what the needs of the population are. And as going through this process, it's been particularly well received regionally and nationally in our application because of how we have been able to articulate that link to why the determinants of health. It's not a health provider application per se. It's the whole population and those wider determinants, and a particular emphasis around place, because what I think we all recognise in Cornwall and the Isles of Scilly is that our places are different, and the needs and the inequalities and the drivers on health outcomes are different in different parts of our system. And I think that's where our strength lies, in being able to understand that at a place-based level and then to implement change. So Health and Wellbeing Board absolutely has a key role here. It's being shared today so that people that have not seen it in its detail have the opportunity to have sight over that, but in particular linking to next week's development session, how then the Health and Wellbeing Board can take its position around being able to articulate a message around health inequalities and how we then really affect change for our people.
Thank you very much, Ian. Amanda Stratford next, please. Amanda, we can't hear you at the moment. Amanda, I think you're off mute now. Oh no, you're back on mute again. Go on, try again. You might be having a technical issue. I think yes, yeah, there you go.
Somebody put me back on. I don't know who it was, but I'll find them. Thank you very much for that. I wanted to say the application really highlights a commitment to putting people at the centre, and that's a really admirable aim. But we all know that mechanisms are required to do that, to ensure people's voice is meaningfully heard. And I really welcome again Healthwatch Cornwall's role and hopefully involvement in developing with people the way that works and a framework for that. But I wondered if just for the benefit of the public and anybody viewing this recording, if I know Helen's passionate about people's involvement, but if she would be happy just to share her thoughts on that. It'll certainly be a key priority for Healthwatch Cornwall in the months and years ahead.
Okay, thank you, Helen.
Yeah, no, happy to do that. So we're doing a piece of work at the moment. Well, we're going to have a workshop in which we start to think about how do we embed the voice of people who use services and the voice of people who have an interest in the way services are going to develop in the future, how their voice is embedded in our day-to-day decision making and governance arrangements. And that can be everything from how they work in the governance arrangements of our localities through to being part of design groups for services. And that needs to be true for all age groups, so children and young people right through to our older adults who are very clear about how they want their services to be delivered as they get older. We made quite big strides in this area, but this really presents an opportunity for us to have people involved from the very outset. So we're not inviting them along after we've worked out what we would like them to do. We're at the outset, we are thinking about how do we make the voice of people a key part of what we do day in, day out. And when we've had the workshop and we've got some propositions that we can bring back to the Health and Wellbeing Board, we'll be very pleased to do that.
Okay, thank you, Helen. Thank you, Amanda. Chris Blong, do you want to come back in?
Yeah, I'm sorry to be the voice of doom, but I think as a system we also have to have an undertaking at every level to start to live within our means financially. I mean, obviously we're looking at an aspirational structure here that puts the person first, deals with inequalities and all of the things that we're all striving for. But the bottom line is we also have to adopt something that allows us to live within our means. And we've consistently overspent year on year for as long as I can remember, and many colleagues will remember. And I think that is something we must also try and pledge to address, the constant overspending, because it doesn't do us any favours anywhere. And I think it's as an important part as getting the health and care provision right for our people. Thank you.
Thank you, Chris. I don't have any more X's in the box. Anybody with any other comments, please indicate to come in. Cornelius, would you like to come back?
I can't let Chris's comment pass unchallenged. You know, there's one person's overspending might be another person's underfunding. I would look at it that way more, Chris, and I certainly wouldn't regard them as of equal importance. I think we've got a duty to lay out what's needed and then ask to be given what is needed to deliver that. I certainly wouldn't worry, I certainly wouldn't say, well, this is desirable, but we mustn't aspire to it because it's overspending. Possibly I misinterpreted you, but I really couldn't let that comment pass.
No, I think Helen was keen to come back on that point. Helen?
Thank you. So it is the way of the world in that we have to live within our financial means. One of the reasons I am so keen that we ensure that people are actively involved in service design and service delivery is that we know that people often, when describing what they want, what will make their life better, how they want their services delivered, come up with better and cheaper solutions than professionals. And the second point I would make is that we all know that if we can intervene early and deliver and address health inequalities and deliver some of those preventive early intervention offers that we aspire to, but struggle to deliver because there is because of constraints on the budget. If we can make a concerted effort to address some of those, that will enable us to get closer to living within our means, and I think that is really, really important, because the truth of the matter is, whilst we can make a case that fairer funding in health and care needs to be considered, ultimately there will be a limit to the amount of money that we have to spend on health and care, and we will have to live within that, whatever that figure happens to be when set.
Yeah, thank you very much, Helen. I'm not having any other indications at the moment. If people are content, we will move to the vote on the recommendations. If I could have a proposer and a seconder for the recommendations, and then I'll read them out. Ian Chorlton's happy to propose and Chris Blong is happy to second. So I'll read out the recommendations. As before, if there's anyone who is against the recommendations or wishes to abstain from voting, please could they indicate in the chat bar. Otherwise, I'll presume you're voting in favour of the recommendations, which are: 1, that the Health and Wellbeing Board review the application for the integrated care system in Cornwall, and 2, that the Health and Wellbeing Board consider its position in supporting the ICS ambitions if the application is successful. So fairly straightforward recommendations there. I'm not having any indications that anybody wishes to vote against or abstain on those votes. So thank you very much, members, and they will be recorded as voting in favour of those recommendations. So I will now move on to our next agenda item, which is our substantive item really today, which is the Health and Wellbeing Board, Health and Wellbeing Strategy and addressing inequalities. I think Rachel Wrigglesworth, were you going to introduce this item first of all?
Thank you, Chair. So this item is, I think, addressing the core function of the Health and Wellbeing Board, as we've discussed. We've adopted a health and wellbeing strategy, a joint strategy for Cornwall and the Isles of Scilly for the next 10 years. And one of our agreed aims was by working together to tackle health inequalities, everyone can enjoy good health and well-being and grow, live and work and age well. So as part of our way in which we operationalise and work together, we have sort of put together essentially a bit of a workshop session at this stage, so that we can not just give you a presentation on what the issue is and describe, which we've done over many years, and presented information to this board describing that people suffer early deaths, that they have shorter lives, that a whole number of our health outcomes are affected by inequalities. I think it's very clear from our joint strategic needs assessments, from our evidence we've brought to the board and presentations, that it's well described. It's not that we don't understand the issue. I feel that the imperative is to move towards addressing and how we do that, and how we work together as a leadership group to address that and move forward in Cornwall and the Isles of Scilly. So whilst we have seen more inequalities as a result of the impact of COVID and a lockdown in particular, I think we're describing some of those things in the report, but actually this is an entrenched issue. It is highlighting some inequalities that already exist. as I say, which we've described before, but have come to the forefront in terms of being in the last sort of 6 months. So I think I really sort of welcome the board's engagement in this session that Dulcie is going to present about the how we do that, and hope to move that forward as a real core part of the function of this board in the next years. So I think I will just hand over to Dulcie to take you through the presentation, and hope you'll engage with that. Thank you.
Great, thank you very much. I will try and share my screen. Make sure I've got the right one. See, file might have been moved. 1 second. Sorry about this. I'm now getting technical difficulties. I do apologise. It has been working before.
No problem. That's fine, Dulcie.
1 second. Right, let's try again. Ah. I don't know why it's not working now.
Rachel, have you got a copy of it that you perhaps could share or not?
I can try that. Yeah, let's give that a go, and you'll have to tell me if you can.
Yeah. Okay.
It's always best laid plans, isn't it?
Yeah.
Well, the joys of remote working.
The technical rehearsal.
It looks like it might be working. We can now see a slideshow, yes, saying Health and Wellbeing Board addressing health inequalities. Do you want to make that full screen on slideshow, and then it should be full size, and then Dulcie will be able to talk us through it.
Does that show full screen, everyone?
Try again, not quite yet. Unless you need to go to slideshow at the top.
The top bar below the brown line. You know, keep going to the right in the middle, says slideshow on it. That's it. From beginning.
Okay.
No.
Hasn't quite come up yet, but
so click on slideshow and then it'll
Rachel,
click from beginning. There you go. Click that one.
sorry, it's Leanne. You need to enable editing. So you need to go to that bar that's along the top, protected view, enable editing, and then go to slideshow, and you should be able to do it then. At the moment, it's not letting you because you're not allowed to edit the document.
I think you've stopped sharing your screen as well now, Rachel, but if you enable editing, then hopefully it should come up. If you bring the slideshow up and then share your screen, it probably will do it then.
Oh, we're all having the same problems.
So if you're not sharing your screen at the moment, Rachel, I don't know if you've stopped sharing or whether you go back into share again and just see if that helps.
Yeah, it seems to be preventing me from popping that up as well. Just give us a moment and we'll work through this.
Sure. If anyone wishes to have a quick comfort break or grab a quick coffee, now is your perfect opportunity.
Thanks, Adam. Is it possible for somebody to load it up into files on Teams and then we can access it ourselves?
That could be possible through the meeting producer or through Leanne. Debbie, do you have any solutions?
Leanne, I don't know whether you have a copy of the presentation.
I don't, unfortunately, but if it was sent across to me, then I can try from my end and upload into files.
I'll send it to you now.
Excellent. Brilliant. Thank you.
So we've all done hundreds of these presentations before, but it doesn't seem to be allowing me to share that screen now. So good luck to that, Leanne.
I've just sent it. I don't know what's happened, but it seems to be fixed. Can people see that?
Yes, I can see that, Dulcie.
Yes, thank you. Excellent. Yeah. You.
I have it as well, so if there is an issue, it's managed to display on my screen.
Right, just as people may have gone for a break now, just let me know if you want me to start.
Okay, we'll just hang on just for a short moment, Dulcie, and then we'll get started. So okay. We'll just give it 30 seconds and then we'll get started again. But yes, it looks like it's loaded in now, so that should be fine. And members can, I believe, using the navigate forward or navigate back arrows at the top just above the presentation, can obviously also move forward themselves to look at the presentation, obviously, as well as yourself as the presenter being able to go through. So I'm not sure who are you able to navigate them forward and backwards, Dulcie, or is it Leanne doing it?
I'm hoping it's me. Yes, if people see that moving? Yeah. Yeah,
I think that's that. Yeah, that looks right.
Perfect.
So yes, it looks like it's working, so that's great. Right, that's fine. I think we will get going now, Dulcie, if you're happy to start.
Great, thank you. So you've seen the paper that was submitted. So this presentation is really sort of add colour and detail to that, and quite nicely now, I hope, builds on the discussion that we've just had about the integrated care system, and particularly what Helen was saying about how that system is trying to work together. So this is just an overview of what I intend to cover. So it's really just to talk about, we know that health inequalities have existed for a long time, and as Rachel said, this is one of the main remits of the Health and Wellbeing Board, is to address health inequalities. I think you had a presentation last time about how COVID has exacerbated existing inequalities, and I'll just cover that a little bit. And then I suppose nationally and locally is even more of an imperative to address inequalities on the back of that. And just to sort of cover briefly, again, what Rachel said, that we know what needs to be achieved from various documents over the last 10 years, but nationally these outcomes haven't been achieved. So the main kind of meat of this presentation is really thinking about how we could work together as a system to address health inequalities, and then there's some questions for discussion at the end. But I thought probably the best thing to do at the beginning was just to get a common definition of some of the key terms that we use. So the first one is, I'll do that right. Yeah, is what is health? So it's quite your first kind of thing that you think about when you think about health, so doctors and hospitals and lack of ill health. But in this context, it's probably a more useful concept to think of health as good physical and mental health, but also leading a flourishing life. And I was listening to a podcast the other day that I think was probably designed for people that were younger and more with it than I am. But the presenter said to the guest, you know, how are you? And the guest said, living my best life. I was like, that, I quite like that in way of capturing health. Full health is your ability to live your best life. So that's the kind of the definition that I'm going to go with through the presentation. So therefore, what are health inequalities? So it's basically saying that not everyone is healthy, not everyone is able to live their best life. And this isn't random, and it isn't a personal choice. We know very well that health inequalities, so that difference in people's ability to live their best life, result from inequalities in social, economic, political, cultural and environmental conditions in which we're all born, grow, live, work and age. And there's sometimes a bit of a confusion between equalities and inequalities. But what I've just kind of added in there is to say that these, you know, the social conditions and environmental conditions that we live in will discriminate, particularly against specific groups of the population, and they're now legally protected under the Equalities Act. So that's how equalities and inequalities sort of fit together. And why does it matter? Well, inequalities impact everyone. It can seem sometimes when we listen to the media or in discussions that we talk about as a group of the population that do really poorly and have poor health and everyone else is fine. And that's not actually the case. We are all on this gradient. So these are graphs taken from the Marmot report, which I'll talk about more in a minute. But basically the grey line is men at the top and women at the bottom. The grey line is life expectancy, and the green line is healthy life expectancy. And basically we're on a slope, we're on a gradient. So it's only actually those that are the least deprived that are living their best life. And the rest of us, and I count me in the rest of us, given the postcode I grew up in and the postcode I live in now and the school I went to and what my parents do for a living, somewhere on this slope. So all of us sit somewhere on this, with the people that live in a better area or went to a better school or have a more control in their job sitting above us in their life expectancy. And this one here is for women, and you can see I've drawn a blue line here. This line sits at around 65-ish, which is the current retirement age for women. And you can see that 50% of women will have a disability or a long-term condition well before they are 65. So this is one of the reasons that it's important that we address health inequalities. And then the other key bit is this is about social justice, and that health inequalities are a consequence of social justice. And certainly the council has said that's one of their main issues to address over the next 10 years is social injustice. And more unequal societies affects the economy, it affects communities, it affects society as a whole. So even if you're sitting at this top end of this gradient, living in a more unequal society is not good. And they were national gradients. Here is a gradient for Cornwall. This is deaths from causes considered preventable. And again, we're all on this gradient. So the least deprived are the least likely to die of a preventable cause, and the most deprived are most likely to die of a preventable cause. And we all sit somewhere on this line, and I will let you decide where you think you sit on that gradient. Okay, so we kind of know this, and we hear that, you know, where you live affects, you know, how likely you are to have heart disease or cancer. But then when you think about how does that actually work, how does where you live affect your health in that sort of way? So there's four sort of key areas, which again you probably know, but I just thought I'd just cover them so they're all on the same page. The first one is biological risks. So if you're worried about money and housing and crime, that is a stressful situation to live in. It increases your stress hormones, inflammation, reduces your immune system, which obviously has a direct effect on disease. The psychosocial risks. So these are beliefs, values, attitude about health and services. And we know that the more deprived an area you live in, the more sort of fatalistic you are, or can be, around health, that this is just what happens, and that there's not a huge amount of point of trying to do anything about it, because that's just what happens. You get arthritis in your 50s, you become unwell. There's increased behavioural risks. And again, this can sometimes be things thought of as a personal choice, but actually a lot of the sort of behavioural risks that we all take can be sort of the flight response to stress. We can't physically run away, but we can drink, we can smoke, we can take drugs, we can eat food that's not good for us to feel better in the short term about the stresses in our lives. And then the structural risks, so the availability of resources. And people that have been around a long time and are well versed in the history of public health will know about the inverse care law. And this still exists today, that the more need there is for healthcare services, the less there tend to be around. It also goes for good food availability. So there's these structural risks that are built in. And they're kind of at the end of the pathway of how social determinants affect health. And I'm going to show you quite a busy slide now. Now, if you've got a big screen, you'll be able to see that in more detail. But basically, what this shows is it just kind of brings together all the evidence that we know about the pathway and the factors that lead from this side, your position in society, where you live, your gender, ethnicity, occupation, education level of your parents, where you sit in society and your power and influence, how that then affects this group of factors, which is your local environment that you live in, housing, type of employment that you can get, stress level. That then affects kind of how you fit within your community. So feeling of community belonging, social cohesion, the social skills you have to work and live in your community, all affects, and there's a huge amount of evidence that all affects your health. How you fit within your community affects the level of social support, the quality of your relationships, and these affect your own sense of mental well-being, the sense of control you have in your life, feeling of empowerment and self-efficacy. And self-efficacy is the idea that you feel you have, that making a change will actually make a positive difference in your life. And then brings us to those psychosocial and biological reactions that affect health. So what this is showing is that the causes and consequences of health inequalities are spread throughout the system. They fit into every department in the council, they fit into every other organisation and service that we offer, from the police and probation and health services and voluntary sector organisations. Any of those organisations can see that what they try and do can affect health inequalities. So just to talk about COVID, I think probably everyone's heard that COVID-19, the pandemic, has affected health inequalities. And this is basically, so health inequalities have already existed, and COVID-19 is now co-occurring alongside these health inequalities. And there's a term that's been coined, which I think is quite useful. COVID-19 has been described as being syndemic. So it's interacting and exacerbating with existing ill health and poor social conditions to increase health inequalities. And that's partly due to the direct effects of COVID-19. So one example would be, as we probably know, people who get COVID have more severe disease, or tend to have more severe disease, if they already have underlying conditions. And we know underlying conditions are more prevalent the more deprived you are. It's the effects of the response to COVID-19, so lockdown, people losing their jobs, not being able to work from home, and then the probable political and economic effects of COVID, so potential long-term unemployment. Will we go into austerity again? Will, as we know, affect people who are poorer and more deprived than the rest of the population. So there are some really good papers written by people in the council and in the health service that I've linked to in the main paper that really go into some of the detail of COVID, but this presentation is more about how we start addressing that. So where are we now? This is taken from the Marmot Review 10 years on. That's basically showing that life expectancy in England has stalled. It had been going up and now it's stopped. The life expectancy gradient has become steeper. So, and particularly for women in deprived areas, life expectancy is actually falling now. And the gradient of healthy life expectancy is steeper than life expectancy, which basically means that people in more deprived areas spend more of their shorter lives in ill health than those in less deprived areas. There's been no decrease in mortality for people aged under 50, and COVID-19, as we've said, is exacerbating these inequalities even further. So what can we do? What works? And we know what works. I'm sure most of you are familiar with Fair Society Healthy Lives, or the Marmot report that was written 10 years ago, that highlighted what needed to be addressed. So it's about giving children the best start in life, enable children, young people and adults to maximise capabilities, fair employment, good work, healthy standard of living, healthy and sustainable places and communities, and strengthen the role and impact of ill health prevention. And I don't think any of those have been found not to be helpful over the last 10 years. I think everyone is in agreement that that is still what we need to do to address inequalities. And that's certainly, this is the from the health and wellbeing strategy, the plan on a page, again, pulls all that through and describes what we need to try and achieve and the underlying principles of what we need to do. So we know what we need to do. That isn't the issue. The issue is, how do we work? So I liked this quote because I think lots of the discussions I've certainly sat in is that people want the silver bullet, what can fix it? And I think I like this. The single most important intervention is to understand that there is no single most important intervention. As we've said, the causes and consequences of health and social inequalities are woven throughout the system. Individual services, directorates or organisations cannot solve this in isolation, and that tackling health inequalities will require the whole system working together. So the question is, how does that happen? How should the system, or how can the system work together? So the next bit of the presentation, I'm sort of proposing how we can describe the system and how we can think about how it should work together as a starting point for discussion. So this is a diagram of the system, and I will walk us through it, each individual piece. So we start, as we kind of discussed earlier, with our person. This can be you if you wish, if it helps you think about it, in the middle. And then we think about the outcomes we are looking to achieve. And these can be the broad outcomes that we've identified in the health and wellbeing strategy. Or you can think about more discrete, more sort of smaller outcomes that would get us there. So in order to achieve outcomes, we need to understand needs. And we often think about needs as being the prevalence of diseases or the prevalence of supportive or risk factors. But what it also should encompass is individual needs. Are people struggling with this sense of self-efficacy, this idea that there's no point in doing anything different because what difference is it going to make, or a sense of self-worth, or not thinking that they're worth making any changes for because what's the point? And I think this is a place where we could and should really use the voice of the communities and the practitioners that work in communities, of really understanding what it is that people need and what are the challenges that they're facing that stop them achieving the outcomes. Now, in our system we want, in our ideal system, we provide services and interventions that completely understand all those needs of every individual and the population as a whole, and can address all those needs effectively. And when we're talking about effective services, this is stuff that should work, that there's evidence for, and that we can really understand why these services should work and that they are effective. And these are services that work directly with individuals or in communities or as a county or countrywide level, such as changes in the law. So it covers a range of services. And whatever service we're talking about, for it to be effective, it needs to be implemented well. And this is drawn from implementation science that has been around for quite a long time, but has really identified what we need to do as a system and as organisations to deliver services that are effective. And there's three key elements. First one is competency in service delivery. So this means that the people that are delivering the service, whatever it is, know how to do it and know how to do it well. And it includes things like selecting the right people, training them well, and supporting them to do the work well. And some of the other work I'm involved in is around people with complex needs. And when you think about the practitioners that work with people with complex needs, that takes a huge amount of tenacity and time to build trust. And that's hard. And so these practitioners need support, whether they're police officers or social workers or nurses, need the support to keep going back and keep working and really help people with complex needs. And that takes leadership, and that includes commissioning and good commissioning. And sometimes, certainly in places elsewhere I've worked, I've seen commissioning say that that's what they want to see in services, but actually putting in key performance indicators and not funding services sufficiently, that's just not possible. So that in our system we want, that needs to be good. And then there's organisational ability. So this is organisations really supporting people to work well. And certainly I've worked in organisations where you could be forgiven for thinking that the organisation is actually trying to make your work harder through not great IT systems, HR processes. So for this to work really well, organisations need to be able to support people properly. And all this doesn't work in isolation. Services don't work in isolation, organisations don't work in isolation, and individuals don't just get one service. We tend to get services from different organisations and different people. So then the key to this, and certainly for outcomes like health inequalities that are set throughout the system, this is then the key bit, is that how does then the system work together and different organisations and different services fit together to be effective? And this is called collective impact. How do we collectively impact on outcomes? And there are five key bits to this. I don't think they call them bits in the official literature, but they're 5 key features. And again, this is what Helen was talking about in terms of the integrated care system. It's about having a common agenda and being clear on really what that means, that it's a shared vision for change, a common understanding of the problem, and a joint approach to solving it, which hopefully would help with the idea of different organisations wanting to do different things that others didn't agree with, that with a joint approach, that wouldn't happen or wouldn't happen as much. Continuous communication. This is described as needing to be consistent and open, and it builds trusts and assures mutual objectives and creates common motivation. And I think the key bit to this is the real how of communication and not just the what of the right papers going through the right boards. It's communication that builds trust and assures mutual objectives. The third bit is mutually reinforcing activities of all stakeholders. And again, I think this sort of builds on what Helen was talking about. The organisations are autonomous, they're different, services are different, but they all need to be part of a coordinated approach and reinforce what each other are doing and not pull in different directions, because that makes things more expensive and more ineffective. The fourth bit, shared and specific measurement of results. So this is collecting data and measuring results consistently to make sure efforts remain aligned. And I think we often measure similar things but slightly differently, and we measure an awful lot of stuff. And this part is really being clear on what questions we're asking of the data we collect and what data is actually required to do that. And then finally, anything that's system-wide needs dedicated staff to coordinate organisations, and this group needs to be seen as as the coordinating group for all organisations, and that different organisations aren't trying to do their own thing, that this group is seen as the core group that brings all this together. And if you have all that, then you have a system that works together in an integrated way and can be effective for system-wide challenges such as health inequalities. Now, all this sits within our local context. You've got the local community context, which includes things like culture, norms, community assets, geography. And then you've got the local organisational context, and this is where the Health and Wellbeing Board sits. And it's that local organisational context that can make the collective impact happen or not. And so this includes things like trust between organisations, real commitment that this is what we want to do, belief in our own staff that we can do it, and a political will to make this happen. And then that, of course, all sits within the national context, and that includes COVID, and it includes the national sense of urgency to fix things now, and it includes reductions in budgets to local authorities. And although we can't necessarily affect that directly, we can certainly lobby and try and influence that, which I think was talked about before, and can mitigate some of the issues. So this would be the ideal world, the ideal system, that if that's all in place, we wouldn't have health inequalities and we would have some sense of social justice. But this isn't quite the system that we know. So we know that we have gaps in all of this, and this isn't just Cornwall, obviously, this is the whole of the country. We don't have the perfect system, and we know that the local organisational context can affect and hinder some of this work, and certainly the national context can come in and change individual outcomes through things like changing the benefit system, and can affect the system that we have currently. So the question then is, how do we get from the system that we know to this one, the system that we want, and how do we address this sort of key ring for the Health and Wellbeing Board around collective impact? So those are the questions that we're posing. How do we create that system support required to effectively reduce inequalities? How do we coherently join together our work so it's mutually reinforcing? And we've got the people from the LGA here, and I know there's a workshop next week. Is it possible? Do we want to use that work with the LGA to help create our approach? So I think Rachel's going to lead some discussion in a moment, but it was just if there's any comments or questions about any of that for the moment. I realise there's quite a lot there.
Thank you, Dr. That's been really informative, and I've got a bit of echo here. I do apologise. Others want to turn their mic off? Thanks. So, Rachel, did you want to come back and just, I think the focus would be around, so that slide there on next steps, and if I just draw people's attention to slide 20, which is the next one, which pulls out in a little bit more detail the areas for discussion, but mindful of the fact and the point you made there at the end, Dulce, about using the workshop as that space to explore that in more detail, and in particular identify how the Health and Wellbeing Board can not only lead related to inequalities, but to help be part of that wider system. So I've got a few crosses coming, but shall I ask Rachel first, is there anything else you wanted to say following Dulce's presentation?
Thank you. I mean, I just wanted to say this is why I work in public health. So thank you, Dulcie, for expressing this as it's a complex system, and I think everyone hopefully has followed that and sees their part in it. So I think I'd be interested to hear, comments and discussion first, but we did pose a number of specific questions so that we can come back and move to some decision towards the end of that. So I'm happy to come back in a little while. I think just wanted to add one thing around that. There are systems that are taking this sort of approach that have had some meaningful progress in tackling health inequalities, and it's a long-term program of work, as you've seen. There's no silver bullet, but I know we have examples from Coventry and more recently as well Manchester, who have adopted this sort of Marmot City type approach. And I think that we can feed in some of that learning during our discussion, if that's helpful as well, but very much around taking an approach which is a common, all of the impact areas that Dulcie's described. They've spent time doing that, and that's what's moved their systems forward in highlighting this. but really interested to hear from board members.
Thank you, Rachel. Thank you, Dulcie. So we'll open it up for comments then. I've got some crosses in the box, and then we'll come back to those specific questions. So I think first on the list I've got Chris.
Thanks, Ian. Thank you, Dulcie. A really excellent presentation, really clear and very thought-provoking. I think a general observation before we get into the next steps questions is, I think thinking back to my distribution and maths and distribution area under a curve and how we get people to buy into this, I think you've got the leading edge who are just going to go for this because they know it's right and they're probably doing it anyway. The majority under the curve who are persuadable in varying degrees but will probably get the message. But my main concern is, how do we address and deal with and support those people who are probably the most in need of dealing with these health and social care inequalities? So for me, it's about how do we target what are going to be finite resources to those areas where we think or we know there will be the biggest need and biggest change required, and hopefully the best improvement. Thank you.
Thank you, Chris. Do you want to come back on that, Rachel or Dulcie?
No, I think they're very good questions.
Absolutely, yeah. Thank you. Cornelius.
Yeah, thank you. Thank you. I've had to change devices, so I hope you can still hear me. The analysis that we've been presented, and the approach that's being described, I find very convincing. But what I know as a person who does a lot of political and other campaigning is that one attitude you're going to be up against is that if people are deprived, it's their own fault, right? And the sort of unhealthy behaviours that cause the prevalence of certain sort of ill health amongst people who are deprived is another manifestation of the irresponsibility that got them to be deprived in the first place. I kind of work on the assumption that nobody present at this meeting shares that social analysis, but it's actually quite widespread outside. So I think you've got to always keep in mind that you've got to counter that mentality a great deal. The other point, when we're talking about interventions, to what extent, as well as talking in general terms, should we be advocating for specific interventions? So, for instance, a very obvious example is the debate about free school meals that's occupied the last few months. Is the organisations that we're a part of, should we actually be coming out and saying we need good quality free school meals to be as widely available as possible? Is that an appropriate intervention? And would it actually be a useful intervention to be even more specific? If more people had access to free school meals of a good nutrition as standard, would that help? In terms of the situation, would that help level up in the way that you've been describing? So, I'd be interested in what you think about that.
Thank you. And I think really going back to that almost that final slide there is around having that common agenda and agreeing what those outcomes are that are really important to our population, and that's how we will engage people rather than it be people saying it's somebody else's fault. So, Dulcie, you've put a cross in the box. I don't know if you want to come back on that particular point before then I invite Amanda and Sally.
Yes, thank you. Yeah, that's exactly that bit in that kind of the community context is exactly that point about social attitudes to why people are in ill health, and there's something that needs to be factored in to say exactly that. How do we address that and to not ignore it, because then that will make the system more ineffective if we don't address that. And then the piece about interventions is very helpful, thank you, because it reminds me that there was an appendix of the paper which was a logic model that gave more detail to that sort of central bit of the system model. And exactly that, when you're thinking about what outcomes are we trying to achieve at a small level, which is good nutrition to children, for example, actually really thinking about what is the evidence of what can work and what does the evidence say of what children need, how the services then need to work, and then you can decide what is the best service we should offer. And if it is good quality free school meals to all children, then we know the answer. But you go through the process to work out exactly what is the most effective intervention.
Absolutely, going through the process and then getting to that consensus, which then gives weight to the argument around that, and of course that wider discussion with the wider population. Thank you. Amanda next.
Thanks, Ian, and thank you, Darcy. Absolutely fantastic presentation. And I was really, I think I'm coming at it from the angle less of where interventions are targeted to address inequalities, and more about how that is actually delivered. So that implementation bit of your diagram, and I suppose building probably on what Chris said, I think there's aspiration there, and we can talk about having system delivery and system thinking and being bought into the same vision. But what actually makes the difference to people is that being walked as well as talked about, and actually walked on the ground and people doing it. So linking into what Chris was saying, I think there's something about needing to understand that moving from organisational culture to system culture doesn't happen overnight, and it certainly doesn't happen without being supported. And so I think there's a question in there for us about how are people supported to work in the way that we want to see them working. And I think that's quite a big question that needs to be addressed. So that was simply my point. Yeah. Thank you.
Thank you. Thanks. Sally.
Was that me, Ian?
It was. I know you were going to swap devices to make it work. So yeah, thank you.
Yeah, I hope I'm kind of swapped and that I'm working. So yeah, like others, I'm really pleased that we're having this conversation. I do think you were right when you talked about it being crucial that we have a common agenda. I do think the pandemic is the game changer here, because I think a lot of us around the table have been having this conversation for some time. It was only a couple of years ago that people talked about, it feeling like we were talking about Victorian data when we were looking at the child poverty statistics, and everybody was very exercised that they wanted to see some change there. But I think the pandemic has really meant that we have got to focus, and this whole agenda has become front and centre of the council and system attention. So we need to absolutely capitalise on that. Food is a really good example. Cornelius has brought it up. It's relatively new territory, but it's become a very key focus. So we've had, the council looking at and being involved with the food parcels to those who are shielding, and through the DEFRA funding, they're looking at the support for community groups who are working in food insecurity. And we've just had the government announcing winter COVID scheme, and this whole attention around food is really worth capitalising on. And some of that is a challenge. Some of that is a challenge because we have money coming and not necessarily the systems that we need. So we're actually needing to build the systems that will help support in this territory. I'm on a stock record on this, but food is both sides of that equation. It's working out how we help people who don't have food, but it's also working out how we help people to have good food, and that whole nutrition piece is important. So that would not be me thinking it's a great thing that McDonald's were offering free school meals for people over half term. We need to do better than that, because nutrition is part of that picture too, not just food. I think that there's just so many things to say, and I don't want to hog it the whole time. I think that starting at the beginning is important. So the work that the One Vision Partnership do around Best Start in Life is really important. I would say that, wouldn't I? But I do think it's important. I think there's some good work coming out from that directorate around belonging as well, which chimes particularly with some of the things that we've seen today about feeling part of community. I'm very mindful of a long conversation with somebody suffering with long COVID recently, and in which they described all sorts of things about what life is like now, but particularly the thing that struck me was talking about feeling loved, being part of how they got through some of the worst bits of it. So that sense of belonging is really, really important, both for individual relationships and for feeling part of a community. And the other thing that I was keen to pick up on was part, and it might have been in the logic model stuff, but it was talking about client strengths. Again, I really think we need to really focus in on where we've got excellent practice. So I know that in children's social care, the signs of safety model being used, that bit about starting from the point of view of what strengths people have is really, really important, that we don't slip into anything that looks like a deficit model, that looks like we're talking about what people can't do. In particular, taking that back to the food question, I spent a lot of time in the last week or so saying that we do need to be careful that we make sure that conversation gives people dignity. So, for example, I'm an advocate of food vouchers, which enable you to go and make choices about what your family are going to be eating that week, as opposed to food parcels, which I understand we have to do sometimes, and in some circumstances might be the thing that works, but it strips you being unable to decide whether you're having beef casserole that night or vegetable lasagna or whatever is important, that you haven't then got that dignity of your own choices that you're making, and it doesn't help build that individual resilience. So I think that how we have this conversation and making sure that we don't at all slip into anything that sounds like a deficit model and absolutely builds from client strengths is really important. So I'm going to pause for a moment to allow other people to speak.
Thank you, Sally. I think the point you were making there, again, that what COVID has given us is that opportunity to have the conversation. Again, listening to the people talking today, it's really animated and put it sort of right at the front of the agenda. So I think for the Health and Wellbeing Board, this is our opportunity to pick up with this and to really say it's the right time to influence. So I've got Miles and Mike coming in next. So should we go to Miles next?
Thank you, Chair. Really interesting presentation, really informative. So thank you for that. I just wanted to make the point really that from a police perspective, social justice or injustice quite often leads and impacts on criminal justice and criminal injustice. And the fact that we are now much more trauma-informed and child-centred in the way we police, whereas, so as a generic example would be where we have serious organised crime groups operated in Cornwall, they will pick on the vulnerable, and the deprived parts of our society, where we would previously look to pursue those criminals, do prevent work, protect work, and pursue work. We're now very much linked into a health-based agenda in terms of, collaboration with health partners across a multi-agency setting, looking at co-producing plans, cooperating, understanding the sort of counter-narrative, and also getting community consensus in what we're doing. So not only are we're successful in the pursuit side of criminal outcomes, we then look to plug the gaps, and so that the criminals don't just replace each other, and have a longevity to community consensus and healthy living and healthy society. So I think we've still got a long way to go. I won't say we haven't, but working in partnership, I think we're all moving in the right direction. Thank you.
Thank you. Encouraging to hear. Thanks. Mike.
Thank you very much, Ian. Dulcie, thank you very much for your presentation. I particularly liked slide 8. I could have used that as a GCSE sociology teacher on certainly a big A3 poster. That would have been absolutely excellent to have. You talked about whole system responses in your role. Do you see housing particularly as one that could take part? Because it just happens the last few days I've become aware of sheltered housing in a way, and I wonder whether one of the ways, as Ian has identified, of using resources could be to see whether our sheltered housing systems or groups within Cornwall had models of good practice or any practice at all in some cases, where they actually do sustain and help people and monitor or help their behaviours. I'm conscious of of some people living in sheltered housing who just literally live in what is called an apartment, and there is no support for them whatsoever, and nobody looking at what they're eating. And obviously under COVID, things are much worse, and I'm conscious of people who living in those circumstances may get themselves into conflict with others, and it may lead to them having health issues, which could have been avoided had there been a practice in place within that housing stock to actually address it. Now, maybe those organisations haven't got the funds themselves to actually do that, but maybe there's a way in which we could actually see that as a starting point to see how we could work. Also, we've got the responsible landlord scheme, so there's lots of people living in private rentals who, with responsible landlords, who could also be made aware of how they could be part of a system for a whole system approach. So how do you feel about sort of the partnership with Cornwall Housing as a start?
Absolutely. Yeah, I mean, housing. You probably couldn't see the detail of a lot of that slide, but housing and accommodation featured in several sections of that, and obviously for human beings, shelter and safe, warm shelter is key to us living generally. I mean, in my day-to-day work, I work quite a lot with people from the housing team. I'm probably not the best person to talk to the detail of sheltered housing within Cornwall, but certainly, you know, I work with some really good people in the housing team that are thinking along these same lines. So absolutely would be a key part to any of this work.
Thank you. I would certainly want to advocate that in some way, and maybe somebody with more experience on this panel might have some ways of how I could go ahead and advocate that, because I certainly feel that there are whole bodies of people, groups of people who need support and help, and it'd be interesting to know where there is good practice in Cornwall. Thank you.
Thank you. And certainly, sort of reflecting back a couple of years ago, the annual report from the Director of Public Health was based on housing and its impact on health outcomes. There are groups, and going back perhaps to the next steps of this conversation is around how do we sort of join together. There is a housing and health group that currently works connected to this board, and it has been and presented at this board in the past. And I do want to say part of our conversation will be how do we understand where this work is ongoing, how can we help support it, influence it from a strategic level. I'm sure that'll be where the conversation goes in next week's workshop. Rachel's put a big comment in the chat. Just let me read through it. Thank you. So Rachel, is that really leading us into the next part of the discussion?
Well, that was one of my suggestions. So it's really helpful to have people's sort of really positive comments back so far. I think it was a really reflection, if we are looking to progress this way of thinking about our collective impact and the elements that Dulcie's described, that the evidence says that we would need in place that would help us deliver those aspirations that I think that are very much supported by the board. So some of they're the 5 areas in that model about having a common agenda, mutually reinforcing activities, continuous communication, sharing specific measurements, and then dedicated staff. And I think it was just wanting to hear from the board about where they think we've got areas particularly of strengths, or they'd like to note for areas that we think we really need to improve on, because obviously we can then build on that outside the meeting. I think there's been some very clear statements from members, and I think we've adopted our strategy that we do have a sort of common agenda at the very high level, but my reflection is that probably that still needs to be reiterated, and we need to be very, I think we've talked before about us being leaders, and it is our statements. It's not a you and you need to do this. It's the boards needing to own that. I feel, having worked sort of in my role for a while, that perhaps an area of sort of securing dedicated staff, and this is a time where there's multiple demands on our time, and in the context of working in a pandemic, but at the same time we seem to be, in my view, missing a joint dedicated staff group that can sometimes participate and help move agendas on for the board, to support the board in its role, which is not organisational but is cross system. So as personally, our team gets nominated to respond to anything in relating to health inequalities, so I just get that just comes straight back to me from pretty much most organisations or queries. So that would seem like, to me, is an area that I'd like to raise. But really interested in other people's views on whether you feel like we need to address a particular area of those 5 areas.
Thank you. So just picking up really on Leanne's comment there that the chat box, the text box is not visible to the recording of this. So just to reiterate that, so what you've asked around is where are our strengths and perhaps areas for improvement around a common agenda, how we mutually reinforce the activities of all our stakeholders, how we have processes in place for continuous communication, how we share specific measurement of results, and in particular that last point you were making around, is there a need or a way that we can identify dedicated staff to help coordinate and participate with our participating organisations to help deliver that message. And I think there probably are examples of that, just reflecting particularly on the climate emergency. Again, that links to this year's annual report, and again the response both within the local authority system partners and across the NHS, and the work that people are being mobilised to try and understand how that impacts our health and well-being within organisations, but the wider population. And that's the sort of work we're trying to bring that all together and have that sort of oversight, if you will, or that strategic oversight here with the Health and Wellbeing Board. I think that's perhaps the question we're asking. So if we go to people who wants to make comments on that, I've got Chris first of all in the who's put next in the box.
Yeah, thanks, Rachel. Thanks, Ian. It's a question really, and I hate answering a question with a question, but how widely circulated and shared has this initiative been? Because to me, as we've said on previous requests, communication is absolutely fundamental, and messaging this out across the community, making sure people are understanding of what our aspirations are, the language that we're using, the rationale behind what we're trying to achieve. And if this is the sort of first landing and it's hit Health Wellbeing Board and then it's going to potentially be rolled out subsequently, then I think we have a communication requirement to get this out, land it in as many areas as we can so people start to become familiar with it. And then perhaps some of the answer to these questions will start to flow from that as we start to get people's energy and responses back in. So I'd be surprised if anyone around this table, metaphorically speaking, is going to object to any of this or say no. But I just wonder whether one of the key asks from this event today is to get this out, get it shared, and start to generate that conversation across all levels of our community, so that we can start to have this conversation as a really widespread, all-encompassing discussion, rather than it just being a sort of diktat from the Health and Wellbeing Board. Thanks.
Thanks, Chris. And so the presentation that was shared, or has been shared during this meeting, and I think I saw a version of it earlier on today. But part of that, and particularly the logic model, it's not the first time I saw that. So I was trying to work out where had I seen it before, and where has the conversation already kicked off. And I believe it was at the Senate within the last month. There was a talk around that sort of approach to inequalities and the use of a logic model, which I think is fed into today. So perhaps I would present that as an example about where it has been part of wider system thinking and discussion ahead of today. Somebody please jump in if I've completely missed the point there. But I think that's where we've got to today. Just to note really for the minute that Helen Charlesworth-Mays had to leave, been called away to another issue. So just for Leanne to note that. And I have Sally who wants to come in next, I believe. Or have I missed? Oh, was it Amanda? I'm sorry. Amanda, sorry. The chat box had so much in it, I lost the train there. Amanda, sorry, you're next.
That's right. Thanks, Ian, very much. Again, supported Chris completely in what he's just said in terms of communication about this plan and aspirations. But referring to communication more as an element of that ideal situation to be in, and continuous communication, for which I'd probably read dynamic communication. I think that's really important, that it's a dynamic conversation. I think we've got some excellent work that goes on in terms of information out to the public, in making it available in various different forms. I think there's some really good stuff in there, but communication is so much about more than just transmitting it. It's about how it's received, and so therefore I would question whether as a system We are in a position as having effective communications, particularly with seldom heard groups, and those are the very groups that very often are in great need of some of the interventions. So I think that is a real area for development as a system to work on effective communication with the public.
I agree, and I think this is the our route or means to an end, really, in effect, and using this from this conversation. I've been really encouraged by the breadth of discussion and how people have received this item. So we'll probably trying to sort of bring things to a close and pick around those next steps. I have Sally next as wanting to come in.
So I'm picking up on the conversation around how we communicate very widely about this, and I think that's true and something that we should do. But I guess I would say that logic models aren't necessarily language that everybody gets. But what I do think that we've got as a document that is reflecting a lot of what we're talking about here is the Cornwall we want. So for me, the fact that we have a document that's gone through quite a lot of processes and across the system, which has got key bits in it, like no child will be dependent on a food bank, is actually something that's much more front-facing and much more likely to be the sort of language that the public will engage with. So I would say that's potentially one of the key drivers for starting this kind of conversation. Whilst we all get it, I think some of the language around the stuff we talked about today would need some work in terms of how the public could key into it.
Thank you. And I think the key behind that really was going back to reflecting what Rachel said at the beginning of this part of the discussion, is around how do we identify the resource of the people or the champions there that provide that connection across partners and organisations to be able to have that coordinated, not only understanding but message. Thank you. I just going down the chat box. Where are we? Cornelius, I think you're next.
Yeah, sorry about that. I didn't realise I was on mute. Can you hear me now, Ian?
Absolutely, we can hear you.
Yeah, that's great. Okay. Well, I wanted to return very briefly to a point raised by Councillor Thomas, which was about housing. Now, I think nothing is more important than housing. I mean, and we could say in so many ways, a point made by the Director of Public Health, I think. But so much housing in Cornwall is the quality of it and how it's delivered, is social housing providers. It's down to them, and they have gone towards a much more business model in recent years, where they judge their performance by how many units they deliver rather than the experiences of the people living within those units. So Councillor Thomas made reference to the point about support services for people living in sheltered accommodation. Well, that's one of the things that's really been cut back by social housing providers. Live West, in my experience, have a lot of sheltered housing in the area I represent. So I'm somehow you need to involve the major social housing providers in this conversation, because they aren't necessarily signed up to the agenda that's been outlined today. I'm sorry to sort of just bring up another task. And in terms of communication, I just wanted to return to the previous point that one of the most essential things that has to be communicated is that ill health is not the fault of the people who are unhealthy, because that's still a very, very popular attitude that needs to be challenged. It's easier to believe that for many people. Yeah, thank you, Chair. I haven't got anything else to say.
Excellent, thank you. And I think one of those asks was how do we have that communication and link, and really picking up on that point around housing. It's been a recurrent theme throughout the discussion, so maybe that might be something that we want to perhaps explore in a little bit more detail. We've made reference to several times around the workshop next week. Conscious this is a meeting in public, a really good sort of debate and discussion this morning. But could I invite Steve to perhaps come in and reflect on our conversation so far as an external observer, and with thoughts about how that we might then take those next steps forward into next week's session.
Yes, thank you, Ian. I'll keep my comments very brief, other than to say I think I've been very struck by the very strong and positive reaction of the board to the paper and presentation today, and the discussion that followed, and it certainly gives Ian Alpin and I some very useful insights to the current thinking of the board as we make our final preparations for the workshop, the development workshop that will take you through next week. One of the things that we will be doing, and I'm going to use this opportunity to forewarn board members, is that we have prepared a questionnaire which sits alongside the framework that Dulcie's set out today. It's not the same framework, but it asks some questions that are useful. That's going to be circulated by email, probably by first thing tomorrow morning, and it's not going to be an onerous thing for you to do. It really is just an online survey where we're going to be asking you to come up with gut reaction to a series of questions, but we would ask you to do that as soon as you receive it, so that by noon on Tuesday we can take a look at the results that have come in from this straw poll questionnaire, and instead of using your development time next week to ask you where you think you're at, we'll be able to take that information and present it to you straight away. So what we want to do is use the workshop for more deciding and doing than necessarily describing. So we'll make good use of your time if you're able to do that. We'll send it out, as I say, by tomorrow, and we will chase you on Monday if we haven't had it back from you. And then now that I've had sight of this presentation, it's very clear to me how we will use the slide that's come up for discussion, this framework that's been referred to around common agenda, mutually reinforcing activities, continuous communication, shared specific measurement of results, and dedicated staff. We can use that next week, and we can explore those those issues in depth. And what we're designing for next week is about action and results, so that you can be really clear that you're not just talking about it, intelligent though the conversation has been, but you are deciding what's going to get done and what results you will see to benefit Cornwall. Thank you.
Thank you, Steve. So I think that leads very sort of nice sort of conclusion around this item, and certainly links it to next week's development session. And again, reflecting on the conversation and discussion we've had today, I think that reflects, and it's always nice to hear sort of an external view of how our discussions have been. But I think that reflects, they said, a mature conversation and really our desire as a board to want to link to practical outcomes and actions. So very much looking forward to next week. So just drawing members back to the paper, there are 3 recommendations on the paper: that the Health and Wellbeing Board understand how health inequalities have been exacerbated by the COVID-19 pandemic in Cornwall, to agree the system approach to addressing health inequalities required as suggested in the logic model, which is what we've been talking about, and then linking into next week, and the next steps for the board to create this approach, as we said, including the use of the forthcoming LGA workshop with members. So they're the recommendations. As with previous items this morning, we'll take silence as agreeing, as voting, but first of all we need a proposer for those 3 recommendations and then a seconder. So I'm looking for crosses in the box. There we go. First in there, Rob Rothschild. Thank you very much, Rob, for proposing that. And initials don't always come and tell me who they are. So who SC was second? Who's SC? I've got a list here. Sorry.
Sally.
Thank you very much for seconding that. All the council, you don't have your proper initials. That's what confuses me. So I made a note at the beginning of the meeting who everybody was. Thank you. So we'll take that, say, proposed by Councillor Rob Rothschild, seconded by Councillor Sally Hawkin. Anybody got any reason to not agree with those recommendations? Put a cross in the box, please. Just to confirm, Amanda, you put a cross in the box. Was that in your head? And wanting to put a second the proposal, or are you disagreeing with what the proposals?
No, seconding.
Lovely, thank you. So we'll take that as carried. Thank you very much, and I'm able to hand back then to the chair, Adam, just to bring the meeting to a conclusion. Thank you very much.
Thank you very much, Ian, for chairing that item. I think that was really good, a really good discussion, and we look forward to receiving Steve's correspondence and looking forward to the development session next week. So that takes us to the end of our agenda. I've not been made of any other business of urgency. I will just check with Leanne to make sure that we've done everything. Leanne, are you content?
I am content, Chairman.
Always nice to have a content Leanne. Thank you very much, and thank you very much, board members and everybody, for your input today. I wish you well and enjoy this pleasant weather at the moment. So I think make the most of it over the next couple of days, because it's not looking very nice for the weekend. Sorry to be the bearer of bad news, but I think more wind and lots of rain. But there we go. Thank you very much, members, and very good. And we'll see you again soon. Hopefully.
Thank you all. Take care.
Bye.
Thank you all.